Well, good morning, everyone. I'm looking forward to addressing you all, and I echo the sentiments shared. It's very nice to see friendly faces and to know that the faces I can't see right now are out there listening. I feel connected to all of you through this. We're just going to take a quick moment. I'm going to move into sharing my screen, and then we'll just take some feedback through Will to make sure everybody can see my screen and the presentation. So just a quick moment here. Well, thank you so much. I'm grateful to be here today. What an incredible impact that we've seen and what we're experiencing right now. Most assuredly, the first time in my lifetime I've seen anything on this magnitude. We're discussing today community and individual wellness in the face of COVID-19. So I'm going to begin by sharing some basic information, and I'm looking forward to taking your questions. As described, we're going to do the format a little differently today. Please write down any questions you might have, and we'll be revisiting that at the end of the meeting. So without further ado, let's get rolling here. Here is our agent in question. I just pulled this image directly from the CDC website. This is this is the infective agent that drives the infection known as COVID-19. And when we hear about it described as a coronavirus, what's actually being discussed are those protruding nubs that are coming off of there that if viewed in a way that gives you a silhouette view, it looks as if it's the corona of a crown. So that's where the name of that category of viral entities comes from. This particular one is named SARS-CoV-2 because this is a very similar infective agent to what brought us severe acute respiratory syndrome, mostly affecting the Orient back in 2003, 2004. Type 2. So this is what it looks like, greatly, greatly magnified. Symptoms of COVID-19. A lot of the information I'm going to be covering here today will be familiar to you, but I hope to be drawing it together in a way that makes it salient and easily understood. So the symptoms of fever, dry cough, and shortness of breath are the three that emerge first. Protracted headaches for many of individuals affected by COVID-19. Then following that, fever, muscle pain, body aches, and then malaise, which is general tiredness and fatigue. So from the time of infection, symptoms appear within 5 to 12 days. And somewhere on the lower end to the mid-range of that, 5 to 7 days, is the most common. But it can happen up to 12 days. This is part of the reason why there's such extensive public health measures being taken to wear masks, to wear gloves, because there's a period of time where we can actively be shedding and sharing this virus without knowing that we yet have it. So per the Missouri Department of Health and Human Services, this is pulled directly from their website. You can see reference at the bottom. Ways in which we help stop COVID-19 spread: wash the hands. We have all heard this 10 million times since the beginning of this outbreak, but it truly is our best protection when we consider the process of picking this up and being able to transmit it to ourselves and then become active infective agents. Hand washing is absolutely crucial. Warm water and a good amount of soap, and the length of time matters a lot. 20 seconds is the optimal length of time or longer. So at 20 seconds with warm water, lots of suds, because what we're seeking to do, the outside of this viral entity is covered in a waxy lipid, and a lipid is a fat. And what we know about fat is a lot of a surfactant, which is what soap is. It reduces the surface tension of it, along with abrasion. The actual friction helps to dismember it. And then the heat helps to dissolve it. So while this as an infective agent is very difficult for us to contain in a public health measure, it's actually a fragile entity. All viruses are relatively fragile. So that hand washing is crucial. Coughing into the elbow to contain and not spread particles, crucially important. And then don't touch the face. We've all heard this, but I will say, and I've heard this echoed by many friends and colleagues that I've been video conferencing with. Now that I'm actually seeing myself on a video screen, I realize I do move to rest my head in my hand or touch my face about 500 times an hour. So incredibly important not to inoculate ourselves. And then the distance. I'm telling patients 6 to 10 feet apart for an extra margin of safety. And by and large, the stay-at-home order that's been enacted here in Missouri and all throughout the nation is very prudent because, again, slowing the spread is crucially important. More information, again, at health.missouri.gov. So Missouri has been under a stay-at-home order since the 6th, and that order continues until the 24th of this month. There's a 24-hour hotline to ask, to receive questions, answers to questions. And then very recently, they began seeking plasma donations from recovered COVID-19 patients. So if you know anybody who has had a verified COVID-19 infection, these patients can now donate plasma. And what they're seeking to do is pull antibodies, because the body's reaction to exposure to this viral entity, like any other viral entity, is to mount an immune response. So those patients who have recovered, which I would like to add will be the vast majority of individuals who are affected by this, will come into full recovery. Those individuals can then help others by donating plasma. More information on that, again, at the website I just provided, health.mo.gov. So Missouri has 4,686 confirmed cases with 133 deaths as of what has been reported this morning. St. Louis County makes up 53 of these deaths. St. Louis City, 19, Kansas City, 11, and then St. Charles County, 10. So patients tested in Missouri by all labs. We've had just shy of 50,000 people tested. And St. Louis County has the most cases at 1,724 cases. So in the United States, total cases as of the close of business yesterday was 579,005 cases. Total deaths at 22,252. Public health, commercial and clinical laboratories are looking at roughly 16.5% of the tests being positive. So of the people who are actually getting tested, they're seeing that strong of a positive response, and then 8.8 at clinical laboratories. So since the start of the outbreak, 17.6% of specimens tested at commercial labs have been positive for SARS-CoV-2. Again, more information can be had on that at cdc.gov, and the link is at the bottom there. So key points in COVID-19, the CDC is modifying our existing surveillance system to track this and to track this particular agent, and we're using models that are based off of influenza tracking, which is done seasonally and year-round, and other respiratory viruses. So we are reassigning capacity and bandwidth, and information is beginning to become more meaningful. It has been meaningful all along, but now we're actually testing at a level. Testing is available that statistics beginning next week are going to be very, very meaningful now. So visits to outpatient providers and emergency departments for illnesses consistent with COVID-19 are elevated compared to what's normally seen. Again, all of this information can be found in an area of the CDC's website called COVID View. You can probably see at the bottom of your page, I've got the hyperlink in there. So once you go to www.cdc.gov, it's very easy to find COVID View. That is a new, as of this week, that is a new interface, and it's going to be a wonderful place to go for updates. COVID View on the cdc.gov website. Overall, cumulative COVID-19 cases associated with hospitalization rate is about 12.3 per 1,000 people. So highest rates in individuals 65 years and older. So I would like to just pause here and say, in the case of this particular outbreak, we know that the most susceptible individuals fit in this age category. And with that in mind, the social distancing practices are aimed at protecting individuals fit in that age category, and also anybody with other disease processes, including autoimmunity or other comorbidities. Diabetes is a good example. Anybody in those circumstances are most vulnerable and will have the toughest time fighting off this infection. So this is the reason for all of our hard work and the incredible, incredible sacrifice our entire economy is experiencing in our entire society. I'm going to move on here. Just a quick glossary. You know, we're hearing a lot of terms used right now. Epidemiology is the branch of medicine dealing with the incidence, distribution, and possible control of diseases and other factors relating to health. And these doctors and researchers working as epidemiologists are scientists studying these diseases within populations, analyzing what causes disease outbreaks in order to treat existing. And this is an important part, prevent future outbreaks. They work tirelessly at times like this. I'm talking sleeping about 4 hours a night and working the other 20 continually. An epidemic is a widespread occurrence of an infectious disease in a community, and a pandemic is occurring over a wide geographic area affecting an exceptionally high proportion of the population. This, of course, is a pandemic. So epidemic versus pandemic, a disease can be declared an epidemic when it spreads over a wide area. If the disease escalates further, an epidemic can become a pandemic, which affects a larger geographic area and a significant portion of the population. You'll hear me speak of efficacy, which is the ability to produce a desired or intended result. This is having to do with medication or other types of support that you can give your immune system. How effective they are is the efficacy. We hear about reservoirs of infections. This is a location within a living or supportive substance where an infective agent lives and multiplies. And then diseases like COVID-19 are spoken of as vector-borne illnesses. And these are caused by either parasites, viruses, or bacteria. Obviously, in this case, it's a virus. Vectors are living organisms that can transmit these infectious pathogens. And then the last is a word that's not heard too often, but it's being talked of constantly. The subject is, a fomite is actually an inanimate object that when contaminated or exposed to an infective agent can hold that. And so when you hear about the length of time that this infective agent can live on different surfaces, on plastic or glass for a very long time, on metals like stainless steel for up to 72 hours. All of those surfaces would be known as fomites. And what's important about that is understanding that if we contact that with our hand and then inoculate ourselves or bring that infective agent into contact with our mucous membranes or eyes, mouth, or face otherwise, we can actually then become a host of this virus. So fomite, the word that's new to many, but incredibly important right now. So community wellness, cooperative social approach, what we are doing now as a world is an incredible coordinated effort to try to contain this. Sheltering in place orders exist now for most major metropolitan areas. Very prudent action. Non-medical companies are retooling to manufacture ventilators and other medical equipment. And just as an example, one of many examples of societal impact, on March 24th, the 2020 Tokyo Olympics were rescheduled. So truly unprecedented to have action like that. This rescheduling of the Olympics had only happened before in cases of World Wars I and II, respectively, in 1916, 1940, and 44. So we are an incredible group effort to contain this worldwide. Let's talk a little bit about severe acute respiratory syndrome, number 2, aka COVID-19. So COVID is an acronym. CO stands for corona, V is the virus, and illness, disease. So COVID-19 is named as such because the outbreak began in 2019. That's where the 19 comes from. COVID-19 is the actual infection, and the agent that causes it is the SARS coronavirus type 2. So it's categorized as a beta coronavirus. Other examples of this are the Middle Eastern respiratory syndrome from 2012 and the severe acute respiratory syndrome that occurred in 2003. All three of these viruses have their origins in bats. Amazingly, bats, why bats? I pulled this from thescientist.com. Why bats make such good viral hosts. And here is a bat with a table full of RNA sequences. Virus, definitely a sciencey, dorky picture, but a funny one at that. Not making light at all of the impact of this. But for bats, the reason why bats are incredible reservoirs is they can carry factors like this and not be affected. We don't know exactly why, but more information is being gathered because this information can be helpful to understand how to treat it. One of the factors seems to be this STING, which is an acronym meaning stimulator of interferon genes. So interferon is an active agent that's produced by the immune system in order to ramp up the ability to fight infections. And we hear about it when a body is fighting a disease process like cancer. Infective agent like a virus or bacteria involves this interferon being ramped up. And it appears that for bats, they have the ability to fight something and then drop that inflammatory response, and their body actually goes kind of senescent in the case that they're not actively infected, they're carrying it, but their body has already battled and won. So they are reservoirs for these type of agents. And all three, the Middle Eastern respiratory syndrome, the severe acute respiratory syndrome, so MERS, SARS-1, and now SARS-2 are all found with reservoirs being in the bats. So severe acute respiratory syndrome, in this particular case, the reason why we look back is the government reaction in different countries around the world to this has varied drastically. And those who have had the best outcomes learn their lessons from the outbreak in 2003 of SARS, and then the MERS outbreak in 2012. And those countries that prepared, had the testing materials ready, had communication between epidemiologists, between the government organizations, and the healthcare systems, had the best preparation. Okay, we hear of Singapore and their incredible response to this, Korea and their rapid response to this. It has to do with the lessons learned from the past. Middle Eastern respiratory syndrome, you know, in both of these cases, they never reached community spread in the United States, not even close. And this is how we're in such a different place right now. We heard about SARS, we heard about MERS, but they were distant. The two cases of MERS that even made it to the United States were both healthcare workers who were in the Arabian Peninsula, where the activity was high for this particular syndrome. But we never reached a pandemic level in this case. So looking at this, the coronavirus, the severe acute respiratory syndrome back in 2003 was quite communicable. It could be spread relatively easy, but we have a different level of that with SARS-CoV-2, with this particular COVID-19 infection we're seeing. We recognize that the senescent period, the quiet period where we can actively be spreading and sharing this is longer. And so this is how it reaches a level where folks have been inoculated and are sick with this without even knowing it, without having the full symptoms. So much information is available on this. The hyperlink at the bottom of my page here where it says, and I recognize you can't click on this and run to it, but the information you'll be able to find at hopkinsmedicine.org. That's Johns Hopkins University. Much is still unknown. We are learning, but there's a tremendous amount of information being gathered. COVID-19, and of course, we did not have artificial intelligence means to sort data and evaluate it in earlier outbreaks like we do today. So incredible learning is happening right now. So we've talked about this a bit. 2 to 14 days of exposure is where the symptoms appear. And again, most of that's happening at a week or slightly under a week for people. Fever, cough, and shortness of breath. The most common initial symptoms. Seek immediate medical attention with the following symptoms. So if individuals are affected at a level where they're having difficulty breathing, persistent pain or pressure in the chest, and now an ability of a cognitive impact, confusion or inability to arouse, this is an absolute emergency. This is a trip to an emergency department and a call to 911. But many individuals are actually going to find, I'm going to flip to the previous slide here, that fever, cough, and shortness of breath are the main symptoms, a severe headache and some body aches, but they're able to ride this out at home. Now, earlier on, I was being asked, meaning within the past month, past 30 days, I was being asked regularly how to move forward for testing. And there were not a lot of tests available early on with this for a multitude of different reasons. Now that is changing. So if you have any of these symptoms, contact your primary care provider. If you do not have a primary care provider, the local convenient care spots are available to execute on this now. So you can actually get a test much easier now than you could have 2, 3, 4 weeks ago. Be tested so you can know, but you're most likely going to be riding this out at home. The vast majority of the population does. But again, a severe medical emergency, if it moves towards some substantial difficulty in breathing, any confusion or mental symptoms that arrive like that, and bluish lips or face, again, that's hypoxia or oxygen challenges. So we want immediate response with that. So we know that this outbreak originated in China. It's difficult to know exactly how this jumped from the reservoir, which was the bat. You know, there are theories. One is this giant scaly anteater named a pangolin, which is actually a mammal. But this animal was sold in live markets there, and they're actually sold as food, but they're sold live. And the belief is that this acted as an intermediary carrier and then became active in humans. And again, we've seen this type of activation before in SARS and MERS. There's a cat-like animal for SARS called a civet, and in case of MERS, it was actually camels that transmitted, but bats are the original reservoir for these viruses and many others. So looking at this model, we've got cdc.gov providing us with this curve. This is basically, this was devised to understand tracking of influenza. We are in the curve area now, the pandemic interval, somewhere towards the peak. We are not quite there, but in the acceleration phase, and about to crest within the next couple weeks in most of the United States. Let's just talk briefly. We've heard a lot in the news about different approaches. Everybody's trying to respond to this, meaning countries are trying to respond to this in the best way that they understand. But there's a lot of misinformation out there. You know, Sweden is taking a different approach, and so they've gotten a lot of attention, but they are still social distancing there. They're washing hands, working at home, extended restrictions. The difference in planning there was in Sweden, they allowed, and you'll see this on my next slide, but they allowed young kids, because it was recognized and studied that very young children were not succumbing to the disease process of COVID-19. If they became infected, it ran its course and they recovered. There have been very, very, very few cases where kids have been negatively impacted in a substantial way. And there's a number of reasons for this, but from an epidemiological standpoint, what we understand is in order to reach herd immunity, a large percentage of the population being exposed is actually an okay thing. So in the case of, let me put the caveat in there, that population has to be the lowest risk. And in the case of Sweden, what they determined was to let grade school age children to continue going to school and continue to have their sporting events was just such a advantage to the entirety of the population that they allowed that to happen. I wouldn't be surprised if we saw things open up here in a similar fashion. Obviously, the highest risk individuals need to continue to shelter in place. But if once we see things coming back to life, understand that the risk to young children is very low. Now, the very dangerous thing is if it begins to spread through that younger population and we don't continue the practices of separation and social distancing, then the most vulnerable can come into contact with those who are not vulnerable. And that is a very strong caveat that needs to be followed. But that's the reason for the different approach. In Sweden, population of around 10 million people, and their goal was to put restrictions in place that can be kept for an extended period of time. And I thought that was a brilliant statement. The goal was they understood this was going to be a long battle, but they were able to do this in a way that protected the most vulnerable. So they actually kept restaurants and cafes open over there, but changed operations substantially. So table service, imagine a situation where tables are separated by quite a distance, no bar service. You're not coming into very close proximity with large groups of people. And again, they allowed their kids to continue sports practices and activities. Young kids are still going to school, although high schools, colleges have been moved to virtual as we've done it here. So just an interesting study. More information on that at npr.org. There was a wonderful there's a wonderful article on there.
Hey, Dan.
Yes.
And we're about out of time.
Yeah.
Are people able to get this presentation from you?
Absolutely. I'm going to share this presentation. you and Bill both have it in your email
Okay.
already, and then I will be happy to put it up. Would it be easiest to share it to the website?
Yeah, I've got it. So I'll put it on our Facebook page and stuff,
Thank
and
you
we'll,
so
we'll get
much.
it out to everybody. So
Sounds great.
hate
I'm
to
just going
cut
to
you off. We will have more Q&A time for Dan at the end of the thing today. So
Sounds great.
all right, thank you, sir.
Absolutely.